Well, welcome everyone. So I know it's Monday morning for you all. I'm still ending my weekend here. So my congratulations to you on being ahead of the game. I'm going to share my screen. So you asked, I'm Rebecca Miller Kuhlmann. I am a clinical associate professor and the assistant dean for pre-clerkship at Stanford. So I've been practicing neurology for more than a decade now, and I spend a lot of time teaching medical students, primarily in their first and second years. But I'm very happy to talk to anyone who's interested in neurology. And here, being said, I know a lot of you are off screen. I am going to ask you to do a lot of thinking because if it's just me talking, you're going to learn a lot less than if we do a little bit of thinking together. So as long as you're willing to actively think along, you don't have to do a lot of talking, but I will probably ask you to either unmute on occasion or put things in the chat so that I know that you're with me. Sound okay? Awesome. So you asked me to talk about how you can recognize when something is a stroke, which is a really excellent thing to be thinking about. Give me just a second. I need to adjust. So we have a wonderful mix of all of you, some of you who are clinical, some of you who are well into your preclinical education, I imagine, if you're second years, and some of you who are well into your first year but still starting out. So I imagine that there's a whole variety. Some of this will be review for some of you, and some of it might be a stretch, but hopefully if you walk away with something, then we'll feel like we've accomplished something today. So before we talk about strokes versus stroke mimics, I think it's really important that we all know exactly what we're talking about. So I want you to think for a second to yourself. You can either write it in the chat if you're feeling willing to participate, or you can unmute. But what, if you had to define stroke, what is a stroke? What is going on when a stroke happens? I'll give you a second to think about that. So hopefully you've thought, there's a lot of times in medical education where we talk about things, but you might not really be totally clear on exactly what we're talking about, right? So the difference between a stroke and something like a transient ischemic attack or a TIA is in a stroke, part of the brain is actually damaged, right? So there is damage to brain tissue that does not recover. Secondary to disruption of blood flow or oxygenation. So most strokes are ischemic, right? So ischemic stroke means that blood flow is being blocked. So the blood vessel is blocked by either a thrombus or an embolus. And I'll also give you a second to think to yourself, do you know the difference between a thrombus and an embolus? So hopefully you had a second to, we'll give you a little bit of time as we're doing this to be thinking along with me. I won't make you. You seem like you might be a shyer group with chatting, which is totally fine. So a thrombus is something that forms locally in a blood vessel. An embolus is also a blood clot, but it often forms in the heart, right? And then as the heart pumps, if you have something like atrial fibrillation and the blood isn't moving smoothly, then you might have some blood that's stagnated, which causes it to clot. And then if you pump, especially of a patent form Raymond O'Valley, then that embolus can go up to the brain. So clot that forms locally versus clot that forms distantly. And then about 20% of strokes happen from some kind of hemorrhage, right? So you can also disrupt the normal blood flow in and out of the brain if there is bleeding. Most hemorrhages are small hemorrhages due to high blood pressure. But of course, aneurysms are another cause of hemorrhages, and as is any type of trauma. Okay, so this is stroke. This is what we're going to talk about. With any neurologic patient I give you, so I'm going to give you a couple different cases to think through today. There are 3 steps that you should always go through. And of course, I think you all learn an approach to any type of symptom where you think about, what is the symptom? What are the associated symptoms? What is the onset? Is there things that make it better or worse? All of those sorts of things. With neurologic symptoms, clarifying the onset and the time course is really important. But then before you move to your differential, your list of things that might be happening, it's really, really important to take a second and localize, right? What part of the nervous system is this constellation of symptoms, is this pattern most likely to localize to? So we always localize before we think about the differential or the etiology. So when we're looking at a pattern of symptoms and we're talking about, is this a stroke? Before we get there, we talk about, okay, is this pattern of symptoms likely to be in the brain and the spinal cord, out in the nerves, before we get to the etiology. So we'll go through this a bunch as we work our way through a couple cases. And so I have cases today that represent stroke and represent not stroke, and we'll go through some of the differences. So first case, we have a 72-year-old gentleman who's coming in with atrial fibrillation, abrupt onset of right-sided weakness and aphasia while eating breakfast 2 hours ago. When he comes in, he gets vital signs which are normal except for high blood pressure. He's unable to lift his right arm and he has a facial droop on the right side. When he talks, he has kind of a halting speech with word finding difficulty. In contrast, I'll also share the case of a 42-year-old gentleman who also woke up with right facial weakness this morning. Well, I guess the difference is he woke up with it. This guy was eating breakfast. So in this case, we don't know exactly how long the symptoms have been going on for, right? Weakness of his facial weakness is present in the forehead, the eye closure, and in his smile on the right. His blood pressure is normal, and there's no other associated symptoms. So take a second and think to yourself, if you had to put your money down, and I'm sure all of you are capable of doing this no matter what level you're at, which of these people is more likely, do you think, to be having a stroke? But more importantly, why? And there's a couple different reasons why for each of these. So I'm going to give you a second to think to yourself. We'll give it about half a minute here, and then we'll talk through it. So again, which things make you think stroke is more likely, and which things might be reassuring? I want you to think about it. Good question for both patients. Okay. In both patients, which items make you think, oh, this might be more likely to be stroke? Which things make you more reassured that it's not stroke? So we'll do the exercise to yourself, and then I'll talk through it out loud in just a second. So for this first patient, as a neurologist, for the first patient, good. Both of these patients need risk stratification, though. So you are correct. This patient is much more likely to be having a stroke. Let's talk about some of the reasons why. Some of these should feel pretty intuitive to you. So first of all, age is a very strong risk factor for stroke, right? As is gender. So the fact that the patient is male also makes them slightly more likely to be having a stroke. But in both of these cases, older patient, much more likely to have a stroke. Patient with vascular risk factors, especially atrial fibrillation, that's one of the strongest risk factors for stroke. Diabetes and hypertension are also very strong risk factors for stroke. Second thing is the onset, right? So abrupt onset is one of the classic things that makes you concerned about a stroke. Now, that being said, there are certainly other things that are abrupt in onset that are not stroke. Seizures are also often abrupt in onset, for example. Next thing, the high blood pressure at presentation, again, raises your concern for stroke versus a normotensive patient. The high blood pressure both is a risk factor for stroke and it's a bodily response to stroke. So when part of your brain is not getting enough blood flow, you have a reflexive reaction where your blood pressure will go up in order to try to perfuse that blocked section. So again, it can be both a risk factor for the stroke, and also most people actively having a stroke will have high blood pressure at the time of the stroke. Next is the pattern, right? So unable to lift the right arm with the facial droop. So right arm and face weakness with word finding difficulty is a pretty classic stroke syndrome. Some of you, especially in your second and third year, do you know what stroke syndrome this is? What vascular territory tends to cause this? If you do, you can put it in the chat. While you do that, I also want you to think about what's going on with this other patient. So we're going to localize both of these and talk about why one of them is stroke and one of them is not. Give you a second to think. Good. I see a lot of really good thinking happening here. So yes, so for this patient, when we try to localize, you're entirely right. All of the answers I see there are you're up in the brain, right? You're above the brainstem, somewhere in the cortical spinal tracts, either involving the motor cortex, the internal capsule, the subcortical fibers as they come down, right? Um, for to have the word finding difficulty, that actually tells us that cortex is involved because to have aphasia. So it actually does put us probably out somewhere, in the cortex. And yes, that tends to be the classic middle cerebral artery syndrome on the left. So an MCA stroke, this is how one of the ways that that will present. What about on the right side? And again, definitely don't feel shy as we're working through things. I mean, we'll get to the right answer, but the most important thing is that you're thinking actively about it. So this gentleman who has weakness of his whole face and nothing else going on. So I told you, I always think about the time course. So this is something that could have been abrupt or could have developed overnight a little more slowly. We don't really know from the way I wrote the case. So the time course isn't entirely clear, which is often how people are in practice. We don't always have all of the information. And then localization. So localization of whole face weakness, including the forehead. Anyone know where this localizes to? It's totally okay if you don't, but I'll give you a second. If you have a good guess, and again, don't worry about whether it's right or wrong, but do a little thinking and tell me what you're thinking in the chat. I'll give you a second. Good. So I see brainstem and facial nerve, which are both potentially correct answers here. So what we see here, well, here actually, you know what I want to do? I want to actually go down to this slide first before we talk about titrating suspicion. Oh, let me reshare my screen. There we go. So yeah, so the second patient has a lower motor neuron pattern of facial weakness, and the first, probably, I didn't give you the full exam, probably would have an upper motor neuron pattern. So this will be review for some of you and new for some of you, which is pretty cool. So an interesting thing that happens in our body is that our forehead gets bilateral innervation from the cortex. Okay. So if you have a lesion up in the cortex from a stroke, it tends to spare the forehead, as many of you have probably learned. So when that's the case, so when someone comes in having a stroke, the lower portion of their face will be droopy. But if you ask them to raise their eyebrows and wrinkle their forehead, that motion will still be symmetric. And I will tell you that most of the time, eye closure is also spared in stroke. Most of the time, someone with a stroke will be very droopy down here and their smile will be very asymmetric, but they will be able to close their eye normally. Whereas someone with a facial nerve lesion, a Bell's palsy, a seventh nerve palsy, usually their entire face is paralyzed and they do not have the ability to close their eyes or to raise or lower their eyebrow. And that's because it doesn't matter if there's bilateral innervation if the lesion is down here. So when you have a lesion either in the brainstem at the level of the facial nerve nucleus or in the exiting facial nerve, you will get a whole facial palsy. And that is the diagnosis for that second patient who is suffering from a pretty classic, what's called a Bell's palsy, which is an idiopathic issue that happens to the seventh nerve. We think is likely viral and we treat it with steroids. It is not a stroke. It has nothing to do with blood flow. Going back, so titrating suspicion again for strokes versus stroke mimics. So you thought about this a bit yourselves and we talked about it, but just to call it out, when it's sudden onset, your suspicion for stroke should go up, especially when the patient has older age, has vascular risk factors, including high blood pressure, AFib, diabetes, smoking. There's other vascular risk factors if they're hypercoagulable because they've had cancer, if they have anything that predisposes them to stroke. You should also be more suspicious of stroke when there's multiple deficits. So the difference between those two patients, right? The one had face and arm weakness plus was having trouble talking. The other just had an isolated facial droop, which is less likely to be stroke. You can never say never for any of these things. None of these are absolute. They all just raise or lower your collective thinking about the stroke. For example, there are pediatric strokes. There are patients, who are young who have strokes for other reasons. So the younger patient is not always not a stroke patient. And then the more you learn patterns, that quote at the beginning of this lecture, that neurology can be learned stroke by stroke, is truly how neurology was learned before we had MRI scans, before we knew nearly as much about the brain as we do now. We learned what strokes were essentially by the patterns that we saw on CT scans or autopsies, actually, and connecting those to what the patient had. And so there's many patterns that you learn that help you to recognize strokes quickly, like the MCA syndrome that I shared. Stroke mimics are more likely to be gradual in onset. So if the symptoms are developing, stroke should develop usually within minutes. They might get a little worse, as the stroke evolves, but usually the deficit happens pretty abruptly. Many of the mimics will develop more along hours, days. Some younger age should give you a little bit of a pause. Of course, if the deficits get better, and if there's a clear inciting event like a seizure, if there's hypoglycemia and a diabetic, which is a really classic stroke mimic, or of course, if there was some kind of trauma, then you should be thinking about other things. If there's a cancer history that might make you more likely to suspect that there's a metastasis instead of a stroke. So those are some of the things that might give you pause. So because I mentioned the MCA, I thought we could take a second and take a look at the anterior circulation. So again, in terms of patterns, two main blood vessels in the anterior part of the brain, correct? We have our MCA, which has this green vascular territory. So here we're looking at the brain from the side. Here's the temporal lobe, that kind of boxing glove view. You've got your cerebellum down here. And you can see that the MCA does a good bit of both your motor cortex and your sensory cortex, right? But this bit that's right in the middle that, again, is colored in red here. Looking at it from the top down, you can really see just the middle part of the brain is your ACA, or your anterior cerebral artery. And if we go over to look at our homunculus, right, I always remember the man, essentially, or the person with the leg kind of drooping down into the middle of the brain. If you keep that image really clear, it helps you to remember that ACA strokes tend to have leg weakness, and MCA strokes, if they're affecting territory more out towards the cortex, they tend to be face and arm more so than leg. The only catch to this is an MCA stroke that's affecting a bigger vascular territory. So it gets a bunch of the deep fibers, will also get those leg fibers as they come in towards the internal capsule. So MCA can be entire hemiparesis, as someone mentioned in the chat, with face, arm, and leg. But if you see a patient with face and arm weakness and other things that make you think stroke, you might be thinking, oh, this might be an MCA stroke, versus when it's more leg, then you think about the pattern of ACA and the anterior territory. Any questions thus far before we keep rocking on? You're all still with me? I'm going to assume you're all still with me unless you tell me otherwise. Okay, wonderful. So yes, we've got right MCA for this patient versus a right Bell's palsy or a seventh nerve palsy, which again, as you will see, this is a very common thing. We think it might have to do with a herpes virus or some other virus, that essentially the facial nerve gets some kind of infection and it gets a little swollen, and the facial nerve traverses when it comes out through some smaller structures, and we think it kind of self-strangulates, and then you get this palsy. People tend to recover from it to varying degrees. Some people are actually left with a permanent facial droop, and some recover entirely. Okay, So we talked about stroke versus it's a mimic in a patient with facial weakness. Now we'll talk about one of my least favorite things, which is dizziness. Everyone who does neurology either grows to really love or really hate dizziness just because it's so vague and people mean so many different things by it. But dizziness is yet another thing that has quite a long differential that sometimes can mean stroke and sometimes doesn't mean stroke at all. So, patient one, 55-year-old woman, has high blood pressure, is coming in with 2 days of episodes where she has severe vertigo lasting 30 to 60 seconds at a time. It happens when she rolls over in bed or when she's looking upward. No other focal neurologic deficits. Her hearing's fine. Blood pressure is a little high. And when you do an exam, you get this left beating torsional nystagmus when you do a specific exam maneuver called the Dix-Hallpike. Give me like you guys can do like the symbols, right? Give me a thumbs up if you've heard of the Dix-Hallpike or some kind of reaction. Because if not, we'll talk about it briefly. Okay. I'm not seeing a lot of thumbs up, so let's pause on that just for a second. So when a patient comes out, okay, I have 2 thumbs up, that's good. When a patient comes in with dizziness, one of the things we're always trying to do is localize, right? So is the dizziness from the brain? Is this a cerebellar or brainstem problem? Because that will give you dizziness, and that could be a stroke or something that needs very immediate attention. Or is it a problem of the little rocks in your ears, the canalets, that can get out of whack from either any number of things? Often viruses will do it, and or air travel, scuba diving, swimming, lots of things can make those rocks get a little bit, out of whack. And when that happens, you can get positional vertigo. So the Dix-Hallpike maneuver, you take the patient. If you Google this, you'll get some really nice images. You essentially lie them down pretty quickly while supporting their head, and you turn their head kind of to the side and back. You do that in a way that makes the rocks in the ear move, and it can either actually be therapeutic in someone who has the canalets that need repositioned, or it can just reproduce their symptoms. In this case, you get this torsional nystagmus when you essentially lie the patient down and turn their head rapidly. We also have a 65-year-old woman who has hypertension and diabetes, coming in with sudden onset severe vertigo, diplopia, so double vision, and ataxia, so trouble with coordination at 3 p.m. this afternoon. Also has difficulty swallowing and has dysarthria, so speech is slurred. And on exam, they have vertical nystagmus. Blood pressure is 182/98. So I'm going to assume that you all have a sense of which of these patients is more likely to be having a stroke, but I don't want you to tell me which patient. I want you to tell me why. So I'm going to tell you that the patient on the right-hand side of the slide is more likely to be having a stroke, which I think that you probably will all agree with me. Tell me one reason why. What's one thing that raises your suspicion for stroke in that patient specifically, in the 65-year-old? Yeah, the sudden onset is a huge one. The timing, the high blood pressure. Again, now they both have a bit of high blood pressure, but this is more high. The thing with dizziness, that's also a pretty large clue, is you should always be worried if you see vertical nystagmus. Okay. So nystagmus that happens with dizziness from the ear is usually horizontal, or it can be torsional. So you definitely, our bodies do not follow the textbook. We learned that horizontal means peripheral ear, and vertical or direction changing means it's in the brain. In real life, the nystagmus you would see in this patient on the left often has this little bit, it's almost like it's got a little bit of an arc to it, but it's left beating. So typically this patient, let's say when they look to the left, it'll be beating pretty fast. When they look to the right, it's still left beating, but a little slower. So nystagmus is an abnormal beating of the eyes that you can see either with an ear problem or a brainstem cerebellar problem. For the first years among you that might not have learned that yet. If you see vertical nystagmus or direction changing nystagmus, this patient needs a workup for a stroke, especially with older age, vascular risk factors. As you mentioned, a lot of different neurologic deficits. So they meet a lot of those red flags for stroke. So suspicion for stroke in this patient should be very high. And so, yes, at the end of the day, patient number one has something called benign paroxysmal vertigo. They essentially need to do some maneuvers to get the canaliths in their ears that, are floating around in the endolymph kind of wedged back in place. And this patient is likely having a posterior circulation stroke and needs care and attention for that. So going back to the vascular territories, just while we're talking about stroke, so we talked about in the front of the brain, to remind you, you've got the MCA and the ACA. And remember, ACA is leg. MCA is either face and arm, or it can be face, arm, and leg. You don't need to memorize all of this, in my opinion. You'll learn and forget it several times unless you become a stroke neurologist. But looking at the underside of the brain up, so we have the brainstem here. You've got a little bit of the cerebellum here, and these are the inferior temporal lobes here, right? So this is showing, and let's come over here. So when I say anterior circulation, right, you've got your carotids coming up, and then they have the MCAs and the ACAs shooting out. Posterior circulation is your vertebral arteries that are coming up in the back of your spine, joining to your basilar and giving off quite a few different branches that all do different chunks of the brainstem and cerebellum. So, and there's quite a few different combinations of places here that can cause vertigo. Parts of the brainstem where the cerebellar fibers are descending, or anywhere in the cerebellum, you can get pretty bad vertigo. I will tell you that these patients don't come in a little dizzy. They come in with the worst nausea and dizziness of their life. It's not episodic like the patient we saw. It's constant. They can't move and they feel absolutely miserable. So before we leave dizziness, some of you who are on clinic may have heard of the HINTS exam. And some of you, I'm sure that this is far in the future for you. But when someone comes in with dizziness and you are trying to decide, is this a stroke or is this just a benign ear problem? This is an evidence-based exam that can help you. So peripheral vertigo from an ear problem, most often episodic. And as I mentioned, you tend to have nystagmus, so those beating eye movements, they might not be present at all. And if they are, they're usually horizontal or horizontal with just like a little bit of torsion. These patients will also have an abnormal head impulse test, which means that their vestibular ocular reflex is a little bit affected. So what you do for the head impulse is you hold the patient's head and you kind of get them to relax their neck a bit, and you tell them to make eye contact with you, and then you jerk their head away from you. And you ask them to keep their eyes on your nose. Okay. A patient who has a peripheral vertigo, their eyes will jerk away and they'll have a catch-up saccade, typically only in one direction. And then they will not be having things like double vision, okay, or any of those other dysarthria, ataxia. Skew deviation is a way you can test for double vision. I will tell you that most of the time, if someone's eyes are newly misaligned, they are going to be telling you, I'm seeing double. So I've never found this to be the most helpful test, but it's part of this evidence-based exam. So skew deviation is the patient is looking at you and you cover both of their eyes and you look to see if the eye actually moves when you uncover it, and you do it with both eyes. If there's a subtle misalignment of the eyes, it can come out when you cover one eye, and then when you uncover, they'll kind of realign. So you'll see this little vertical movement of the eyes if there is skew deviation. It's a sign of like a very mild diplopia. But again, most of the time, if the patient can talk, you're going to hear from them that they have this diplopia. So here, essentially, what I'm saying is that the eyes will have normal alignment when it's an ear problem. If they're having a stroke, you get all of these other D words from brainstem pathology. So trouble speaking, trouble swallowing, trouble with double vision, dysmetria, right, is your ability to meet a target. You'll have the direction changing nystagmus. Your vestibular ocular reflex isn't going to be affected because we're central, we're not really out in the nerves. And then you can have skew deviation if the eyes are misaligned. And while we're talking about the D words versus the A words, as you start working on just memorizing these different, and I will tell you, if you go into neurology, you don't end up really having to do a lot of memorizing because you just see the patients and you remember the patients. Like I have a patient in my mind who had a posterior inferior cerebellar artery stroke, a pica stroke, who had the worst vertigo and nausea of his life. And I can tell you exactly what he looked like. And I based a lot of that case off of him. But essentially, as you're working on figuring out where do these different patterns fall, memorizing the A words versus the D words can be helpful as you're trying to localize. So the A words are all of your cortical signs, aphasia, so trouble speaking. That can be your Broca's aphasia, where it's hard to get words out. Your motor aphasia versus your receptive sensory aphasia, Wernicke's, where you can certainly talk, but you're not really understanding. You can have visual field cuts or anopsia. Agnosia is your ability to pay attention to both sides of the world. Apraxia is higher motor integration. So your ability, I had a patient come in once who had a very specific stroke, and all he came in with was a tiny amount of apraxia. So his motor cortex was fine. He had strength, but he couldn't use his strength and integrate it with his other senses. So he came into the hospital because he went to turn the key in the ignition of his car before we had any push to start. And he couldn't figure out the motion. Like he couldn't do, if you think about it, to do that motion, there's a sensory piece. You're holding the key, you're looking at it, you're visually seeing the keyhole, you're finding it, and you're doing this turning motion. It's integrating a lot of different things. If you have a stroke in some of the areas that do that integration, you can get apraxia. So you might be able to feel, you might be able to see, and you might be able to move, but you can't actually integrate them together. Amnesia, memory issues, all of these are trouble reading, trouble with calculations, trouble writing, that sort of thing. So any of these A's tell you that the cortex itself has been affected, almost always on one side in a stroke, right? Because we have blood vessels on both sides. It's very rare for things to be blocked bilaterally if it's a stroke. And then you get the D's if we're talking down in the brainstem or the posterior fossa, so the cerebellum, right? So all of your cranial nerves that do your eye function, your swallowing, and also a lot of your coordination and your vestibular system, right? Cranial nerve 8, their nuclei are in the brainstem, right? So that's why you get the trouble with double vision, with swallowing. Disequilibrium is a fancy way of kind of saying dizziness, right? Discoordination, dysconjugate gaze. Any questions on any of that? Awesome. Okay. So I have a couple of more of these. I think we'll probably get through. I think there's 2 more. So the next one is hand weakness. So kind of similar to our face weakness. I've got 2 cases here, except I started making them a little bit more nuanced as you get used to running through these. So case on the left, 58-year-old patient with diabetes and colon cancer. Acute onset of isolated left upper extremity weakness. No speech or visual deficits. Weaknesses in finger, wrist, and elbow extensors, more so than flexors. No sensory deficits. So it's a motor only issue. Just in one extremity. Same age patient, same risk factors. By the way, colon cancer is a risk factor for being just any kind of cancer can make you hypercoagulable. So you can consider that a vascular risk factor. Cancer does put you at higher risk for stroke. This patient has left hand numbness in digits 1 through 3, weakness in thumb abduction, and some pain in the left wrist. The additional history for them is they were finishing some intense computer programming and have had worse numbness and weakness over the last 3 days. They'd had some intermittent numbness in the past, especially when keyboarding, and no other deficits. So I'd like you to put your money down. Is either of these patients having a stroke? What do you think? You can think to yourself, or you can tell me left versus right versus both versus neither in the chat. So I see a couple people voting for our person on the left. So that's entirely right. So you picked up, they both have risk factors for stroke, right? In this case, the acute onset makes you more worried about the left patient, right? Um, this patient doesn't fit all of those things that increase our concern for stroke, right? They don't have multiple deficits. And like I said, there are exceptions to every rule. This is probably a lacunar stroke, so a stroke of a small penetrating blood vessel. So it hits a much smaller, often it'll hit like a little piece of the infernal capsule. And with lacunes, you can get a pure tiny motor stroke, a pure sensory stroke, etc. Whereas on the right, this is a pretty classic carpal tunnel syndrome. Um, the point I wanted to make here is actually a localization point. Okay, but let's talk about lacunars first, just while we're on the subject of stroke to, again, I'm sure review for some of you and new for some of you. I mentioned that there's a couple different ways for blood flow to parts of the brain to become disrupted, right? So an embolic stroke, most often the emboli comes from the heart with AFib, but it can also actually come from the aorta or really anywhere in the proximal blood vessels, but it breaks off the emboli and it goes up, right? Those can cause large or small vessel strokes. Often embolic strokes are multifocal if the emboli break off multiple places. A lacunar stroke is any of these itty bitty penetrating blood vessels. They tend to be deep in the brain. They can hit the thalamus and the deep gray structures. They often get the subcortical fibers or the internal capsule. And that you can think about those as just like they're kind of slowly often getting clotted off by something like a cholesterol plaque. And then you've got your thrombotic plaques that can be anywhere that can also, slowly close a large or a small blood vessel. Now, the point I wanted to make about this patient who has numbness in part of a limb and weakness in part of a limb, right? So numbness in digits 1 through 3 and weakness versus this patient who has weakness of kind of the whole limb and no numbness. Why this one, from a localization standpoint, is so much more likely to be stroke. Because I don't think I understood this until I was well into residency. So carpal tunnel syndrome, right? You have your median nerve that is carrying motor and sensory fibers. It gets caught under this ligament, especially doing things like keyboarding or driving sometimes can bring it on. You get numbness in these digits. You can get weakness of your thenar eminence. It's a nerve problem. In order for someone to have numbness and weakness in part of a limb from a stroke, you're inducing a blood vessel that happens to be getting, let's say, the sensory part of just the hand, but also the motor part of just the hand on the same side. So it's getting like right here, but nothing else. That just doesn't happen. Like blood vessels don't work like that. So if you have, a little tiny blood vessel that's clotted off, it's usually going to cause just like a small motor issue or a small sensory issue. But it's not like you don't ever get it where it just happens to get just the sensory portion and just the motor portion of the exact same part of the body, just because of how the brain is mapped out with these being on two different sulci. So if you see numbness and weakness in part of a limb, even before you're checking for reflexes and checking for tone and all the other things that can help you understand if you're upper motor neuron and in the brain and central nervous system versus lower motor neuron and out in the nerves, just that localization, the fact that it's numbness and weakness together in part of a limb, you should think nerve, or nerve root before you think anything else. That makes sense? Cool. So this is where I got really ambitious and gave you a whole bunch of different cases. And we're just going to go through these a little bit more rapid fire now that we're in a rhythm. So first, we've got someone who's middle-aged. They're found down, so we have no available history. But as this dude starts to regain awareness, he's confused and has left arm and leg weakness. Could be a stroke, could not be a stroke, right? I'm just going to talk these through out loud. I have no idea at this point. Left arm and leg weakness, and without having the history, I'm going to assume stroke until otherwise, right? Until I get more history on this guy. Okay. We'll come back to him. Let's go to my second one. So this guy has more history. 62-year-old man coming in with confusion and left-sided weakness. And his medications include insulin as well as atorvastatin and aspirin. I'm also worried about stroke in this guy, right? He sounds like he probably has diabetes and high blood pressure. And he's got left-sided weakness. I don't know. So I'm worried about stroke in him, right? This guy Again, 62-year-old, sudden onset, left leg weakness, and behavioral changes. Okay, so sudden onset always makes me worried about stroke. These two I don't really know about the onset, right? So this third guy, family notes he was limping and displaying behavioral changes over the weekend. So it was sudden onset, but they didn't bring him in right away. And he's apathetic. Okay. This one, to me, as a neurologist, I'm the most concerned about stroke so far. And then 62-year-old brought in by ambulance, confused and dizzy, febrile, tachycardic, hypotensive. I'm already not concerned about stroke in this guy, right? I'm concerned about him, but I'm much more concerned about infection, right? So let's come back to patient number 1. So found down, no available history. We finally get further history. This guy has a history of seizures that start with left-sided shaking. So when he comes in, he's weak, right? He doesn't have shaking now. But this is a really classic stroke mimic. And often these patients will get treated. They will get clot busting medication to treat them for stroke in the moment if we don't have this history, because Todd's paralysis can look a whole lot like a stroke. Todd's paralysis is after the cortex is hyperactive from a seizure, from an electrical storm in the brain. It has a period of hypoactivity. So people seize and they shake, and then they get weak. And if you don't see the seizure and you don't know the seizure happens, then they come in with new paralysis. The good news is if you treat someone for stroke with something like TPA or tenecteplase, which is the clot opening drug, and they don't have a stroke, the chance of harm from that is very, very low. You do waste the medication, but the most harmful thing, honestly, is when you treat people who had a stroke, who it's outside of the window and they have a lot of ischemic brain that's likely to bleed. That's actually the danger of those medications. So we err on the side of treating people like this, even though this is very much a stroke mimic. This gentleman number 2, is the second probably most common stroke mimic. And this is why everyone who comes into the emergency room, part of the vital signs, right? You check the airway, the breathing, the circulation, and you also make sure you also check the glucose. So the D sometimes stands for dextrose, right? He gets a finger stick, he's hypoglycemic. For whatever reason, hypoglycemic patients can present with focal neurologic deficits. And if they totally resolve when you give them glucose, it was not a stroke, it was just the hypoglycemia. This guy's having a stroke. So patient number 3, this is that classic, if you remember when I did that rapid fire review of vascular territories, the leg kind of hanging in the middle of the homunculus and the ACA territory, that anterior cerebral artery. Anterior cerebral artery does also all of the prefrontal cortex. So it's pretty common to get some weirdness with either apathy or changes in emotion, changes in motivation, right? Your prefrontal cortex is the seat of self-control, of a lot of the things that we think of that make us human, the ability to emphasize some behaviors and suppress others, the ability to sequence tasks, lots of executive function. So this gentleman definitely having a stroke. And then this dude is sick and he improves with IV antibiotics. But honestly, people who come in septic, until you get that good history and you know what's going on, someone who's hypotensive, much less likely to be having a stroke. But all of these patients can present somewhat similarly. When you get the whole careful history and physical, it becomes pretty clear. Right. I have one more set, and I think that that'll be just right for the amount of time we have together. Are you still with me? I'm going to assume you are. I would make a joke about it being late at night, but it's not late at night for you, right? So, okay, so vision changes. So these are all 32-year-old women. First 32-year-old woman presents with pain and vision loss in her right eye. It started with blurriness, and then the vision gradually darkened over the next 16 hours. At the time you see her, she's got acuity to finger movement only in the right eye and normal vision in the left, 20/20. Other eye totally fine, and there's just no other symptoms for her. This is just pain and total vision loss of one eye. That's patient 1. Middle patient, 32-year-old woman who starts to see kind of this wavy, kind of heat-looking thing, lines in her vision. When you do a careful exam, you find that while she says it's on the right, it's actually on the right side of both eyes. So if she closes the right eye, it's on the right side of the left eye and it's on the right side of the right eye. So it's in her right visual field. Um, this developed over about 20 minutes. And she also has a spot in the middle of her vision that she says she can't see well. It's almost like her blind spot got bigger. And then we have 32-year-old woman with antiphospholipid syndrome and a history of deep vein thromboses and a patent foramen ovale in the heart. So sudden onset difficulty reading and bumping into objects on the right side, reports missing half the page when trying to read. Wasn't initially aware of the visual deficit until kind of attempting daily activities. Visual acuity is kind of okay. And then when you do testing, you find they have a right homonymous hemianopia. So they are missing the right visual field completely on both sides. You don't want to vote for the stroke patient? Tell me left, middle, or right. I could be mean and tell you that it was like all of them, but it's not. Deserve a workup and better history than like these initial little things I'm giving you to think about. So let's start with the left side patient. I'm going to tell you now that she also has a history of bilateral leg weakness from transverse myelitis. So this presentation, before I even gave you that history, is a pretty good story for optic neuritis, so an optic nerve issue. Things that put it in the nerve, complete loss in one eye puts it before the optic chiasm in terms of localization. You can have a stroke of the optic nerve, right, if you get the right artery. So, stroke is still on the differential. The gradually darkening over 16 hours is actually pretty good for demyelination and multiple sclerosis. That tends to be how MS flares present. They present over hours to like a day or two. Symptoms usually peak within about 48 hours, just like with some give or take. Whereas a stroke, it's usually more like minutes to maybe an hour. Like this is pretty long for a stroke. Now, you have to still keep stroke in mind for everyone because you can have things that sort of stutter if a blood vessel's like kind of closing off. You can have symptoms that, you can have exceptions to the rule. Once you have this history of a transverse myelitis, that's a pretty good story for multiple sclerosis. And this in a young woman, that's a more common diagnosis than stroke. Middle patient. So wavy lines and kind of a blind spot. The term you'll see for that in textbooks are scintillating scotoma. So this is a really classic migraine visual aura. And I will tell you in this case, most visual auras resolve within like an hour at most. And they are almost always followed by a migraine headache with nausea and photophobia. Especially in older people, sometimes they just get the aura. And that can be more concerning the first time it happens and will require more of a workup. If it comes with a classic headache and they have a headache history, you can feel pretty good about this patient. And then this patient, so antiphospholipid syndrome is hypercoagulable, has a history of some blood clots and a PFO, which can make a blood clot be able to go up to the brain because you have that connection between the left and right heart. So I essentially, even though this patient doesn't have the age risk factor, I gave them a bunch of other vascular risk factors because this patient is the patient in this case that is having a stroke. This is a pretty classic left PCA, so posterior cerebral artery stroke with the right homonymous hemianopsia. So the last thing I will leave you with is a reminder of the localization of the visual fields, because it just makes so much sense. I mean, that's the fun thing about neurology is the more you learn it, the more you can really connect what you see in the patient in front of you with what's going on in their brain. And then you can use that knowledge to help them, which is like, it's such a fun thing to be able to do. So patient number 1 had optic neuritis, right? So they had a lesion here of just, the optic nerve itself. They're going to lose vision in one eye. If you get a lesion of the optic chiasm because of the way the fibers cross, and you either have already learned this in detail or you'll lose just the temporal side of your vision. After the fibers cross, this is where you can get the pattern from a PCA stroke. So you can get that homonymous hemianopsia where you lose one side of your visual field. In this case, the patient probably had it back here towards the occipital lobe. To remind you, because of the way the fibers are, remember everything is crossed and upside down. So if you have a lesion just down in the temporal lobe fibers, then you get the pie in the sky lesion where you get the superior quadrantenopsia. If you get a lesion in the parietal lobe that just gets these fibers, you'll get an inferior homonymous quadrantenopsia. If you haven't seen this before, you're not going to memorize this from one quick rundown, but hopefully it'll lay some groundwork for later. And if you have, hopefully it's a good review. And then the last slide I have for you is just to go over the brief review of everything we've covered today. So some of the stroke mimics we covered, things that look like stroke that aren't, were a Bell's palsy with a seventh nerve, hypoglycemic patient who was confused but needed glucose, someone who was septic, someone who had a seizure and then had weakness after it. Ear disorders that can cause dizziness, that, you look for all of those other things like the dysarthria, the double vision that would make you worry more about stroke. When it's just peripheral, it's just going to be the dizziness and not all of those other things. I didn't get into functional neurologic disorders and conversion disorder because that would be its own lecture, but essentially there's a lot of different ways that stress and psychiatric things can manifest in the body too. Most of the time, these patients don't have a typical classic pattern of symptoms, and there are things about them that make you kind of get the sense that this is something else. And then we talked about migraine and multiple sclerosis. And the last thing I'll say again, with every patient, clarify the onset and the time course of the symptoms. Take a really good history and exam, and you've done so much of the work. Always localize where it makes sense for the symptoms to be coming from in the nervous system before you think about your differential, because your differential will be much better if you've taken the time to localize first. And that is all I have for you today, but I'm happy to take any questions.
Thank you very much, ma'am, for that wonderful session. So on behalf of ESIC Student Interest Group of Neurology, I would like to thank you for accepting our invitation in a short span of time and accepting an invitation for conducting this international webinar along with us. So if you are fine with the time limit, we have compiled a list of questions which we collected from the Google Forms. So can I ask one by one?
Sure, you're welcome to.
Yeah, ma'am. The first question is, in your published work, you talked about the implementation and evaluation of the neurology communication and coaching program. And the findings there have highlighted the importance of factors like stakeholder engagement, like iterative evaluation for the training effectiveness with key educational strategies. What do you feel as the most effective methodology to improve stroke evaluation, particularly in helping the trainees to distinguish the true stroke from its mimics?
Oh, good question. In terms of how to best help trainees, so you mentioned my paper on coaching. So coaching is a teaching methodology that we use a lot. And the idea of coaching is that instead of me coming to you and assuming that I know what you know and I know what you don't know and just talking at you, it's me asking you questions to help you understand what you don't know, right? Coaching, I think, helps honestly with everything. So when I'm coaching a resident, we'll go in to see a patient. I'll ask them what they're working on. I'll watch them examine the patient, and I'll ask them how they did before I tell them how I think they did. Because most of the time you know what you know and what you don't know, but we're all doing this bit of a performance to try to, appear a certain way. And what's more important is really knowing your knowledge. In terms of helping trainees though with stroke, a lot of it is just seeing patients. Like, you have to have the repetition. You have to have really good knowledge of neurology and of the brain systems and of the different vascular territories. So some of it is memorization, but you can only learn so much from a textbook. When you get those foundations from a textbook and then you've seen enough patients that make it real, that's when I think you really get good at diagnosing stroke.
Yeah, ma'am. And we often discuss stroke mimics more, but there are something called stroke chameleons that are arguably more dangerous. So, from your experience as a clinician, the clinical scenarios which you commonly lead to stroke chameleons, are they under recognized? And if they are, what are the subtle features that help you to catch them early?
The most dangerous things to miss in the moment are the things that could be life-threatening. So, missing an infection, which is pretty uncommon because infections tend to have such a unique set of symptoms. Missing an aneurysm or a bleed that needs to be clipped can be really catastrophic. What other things are especially dangerous chameleons? You know, a lot of the things we're much more worried about missing a stroke than we are accidentally diagnosing a stroke because again, you know, when you treat a stroke, you give a clot busting drug, right, that opens the blood vessel. If you give that to a patient who's not having a stroke, there's a almost 0% chance it's going to do them harm. If you give that to a patient who's had a stroke within the last, 3 to maybe 4.45 hours, it might save their life. If you give it to a patient who had a stroke that's been longer than that, it might cause a catastrophic bleed because too much of the tissue has died. It's that dead tissue in a large territory that's more likely then to die when you reperfuse it. You actually don't want to open the blood vessel back up. But in terms of other things beyond that, um, I mean, again, you never want to miss an infection or a meningitis because it needs antibiotics so quickly. So, but I don't think those get mistaken for stroke all that often. Seizures tend to declare themselves once you have a good history. Yeah, so I'm not sure I have a super nuanced answer for you.
So, we have this increasing dependence on rapid neuroimaging and protocols. Do you feel the bedside neurological examination are still meaningfully changes the decision making in stroke alerts, or are there any exam specific findings that you believe that remain underthought in a clinician perspective, like in undergraduate medical education? Is there any clinical examination that you would recommend that they
Get rid of
should
it.
learn most?
Yeah, no, that's a good question. So even in the acute setting, the neurologic exam is still surprisingly meaningful. And I think that's part of what led me to go into neurology as I went through different rotations. Like it was the only exam that I could see changing management. Even I work in a place where if you sneeze, you might get an MRI, right? Like we image everyone. Um, and that being said, when time is brain, when we do that rapid triage, it makes a huge difference in saving patients from unnecessary testing versus getting them where they need to go and mobilizing those resources as quickly as possible. So we do that abbreviated version of the exam called the NIHSS stroke scale, um, which I'm sure any of you who have done clinical rotations have seen. And I imagine that there is something similar that is used. I don't think that that's terribly country specific. Um, it makes a big difference. And it also helps to triage the patient. It helps to risk stratify the patient. And there's still a whole lot of resource poor settings where we don't have access to that totally immediate imaging. I mean, I live, in a very urban part of California in Silicon Valley, but we are getting patients life flighted in from places in more rural California that don't have access to nearly the same types of imaging. And those exams help to triage which those patients are, right? Who gets flown and who doesn't. So the exam is a huge thing. I think knowing the basics really, really well is more important than knowing anything that's very fancy. Like really being very confident in what normal reflexes are versus when they're hyperreflexic or hyporeflexic, being really good at testing muscle tone and understanding when there is spasticity. Um, and being really good at the cranial nerve exam. And the more you do it on normal, the more it'll be really clear when you see those abnormals for the first time. But I don't think that there's really special weird things that we need to know. I think that we need to be very, very good at the basics.
Yeah, well. And looking back at the cases you found most educational during your practice, what was a stroke presentation that challenged your diagnostic instinct the most? And how has that experience changed the way you approach the stroke today?
That's a really good question. The patients that I'm thinking about that challenged my diagnostic reasoning the most, the ones that are coming to mind the most quickly were not strokes. Um, I'm trying to think of a good stroke one. But for example, I had a patient who had been diagnosed with cyclic vomiting and he was having seizures. He was having vomiting from seizures. Um, and I figured that out because he was altered while he was vomiting and I couldn't actually get his attention. But that one wasn't a stroke. I also had a patient who actually eventually had a stroke from a bleed, and that was a miss. So I can share that one. So hemorrhagic stroke from something called an arteriovenous malformation, right? So he had a tangle of abnormal blood vessels in his brain. And this is, I think, one of the patients I still think about a lot because it's a patient that I did not diagnose. So he came in to neurologic clinic telling me that he was having panic attacks and he had a history of depression and anxiety. And I did a full neurologic exam and everything was perfectly normal. And I chose not to image him. And he had an AVM that bled and he had a full seizure. He was probably having seizures from it. The panic attacks were probably seizures in hindsight. And they were kind of a sentinel for then it bled and he had a stroke. Um, and that's hard because I think even with the best history in physical, you don't catch every patient. And with that patient, I had asked him to come back in 3 months because in the outpatient world, which you see less of in training, when you don't know what something is, you keep following it. And he chose not to come back. So if he had come back, maybe we would have caught it. So that's kind of on him and on me. But you also, 99 times out of 100, the person having panic attacks with a normal neurologic exam is just having panic attacks. So, no exam is 100% either. But anytime that happens, you spend a lot of time thinking about if there was anything else you could have done or missed. So it's hard. It's hard. And there will always be things that will be surprising. And, having humility about them and discussing them is a big part of learning how to be a good doctor.
Yeah. So, as someone deeply involved in education like you, what is the initial motivation that drew you to neurology and neurology science? And what advice would you give to the students who are considering this field, ma'am?
I think I thought about a couple of things. One was truly what I said about the neurologic exam. There's something very meaningful about being able to physically diagnose in addition to the more less personal modalities we use now, like imaging. Another thing to me is of all of the organs, the brain is such a meaningful thing. It's the seat of our personalities and our lives. And so when I was thinking about what organ I wanted to focus on, right, we have a lot of fascination about the brain and there's still a lot of mysteries to it. And the last thing I will say about neurology is even 12 years ago, when I was making my decision about what to go into, it was often thought of a field where you diagnose people, but you didn't really help them. And one of the most amazing things with going into it is how many new therapies we have. Like it's truly, there's something else that's game changing, like a couple times a year with that changes how we can treat and support people. And so it's a wonderful field to go into. I would highly recommend it. So I'm sure everyone says that about what they go into. And quite frankly, I work with people in many different fields and they're all pretty happy. So I don't know that you can go wrong, but if you're fascinated by the brain and how we think and about the idea of what we can do to protect and optimize that, it's a great field.
Yeah, ma'am, I think the message is clear enough. So I would like again to thank you very much, ma'am, Dr. Rebecca, ma'am, for exceptionally taking this session and the way you highlighted the true red flags while also cautioning us against the common red herrings was immensely valuable, ma'am. And it was highly applicable to a real world clinical practice. So we truly appreciate you for the time to share your clinical experience. So as we come to the end of today's session, now I invite Ms. Sophia Mondal, Secretary ESIC SIGN to propose a note of gratitude to you. And yeah, over to you, Ms. Sophia.
Hello. We would like to extend our sincere gratitude to Dr. Rebecca for such a thought-provoking discussion. Your insights into stroke diagnosis and its mimic have been incredibly valuable, and we are truly grateful for the time, expertise, and clarity that you shared with us today. On behalf of ESIC SIGN, we thank you for your generosity in engaging with our questions and for inspiring our students and participants. We sincerely hope to have the opportunity to collaborate with you again in the future. I would also like to thank all our participants for their enthusiastic involvement and all the thoughtful questions that you've come with. Thank you so much, ma'am.
Oh, you're very welcome. It's a pleasure and an honor to get to speak with you. I'm so happy that there are so many of you that are interested enough to spend an extra hour thinking about stroke. So have a wonderful rest of your days, and certainly I'm happy to talk more in the future.
Thank you, ma'am.
Thank you, ma'am. Have a great day ahead.
You too. Bye-bye.